She's an expert in all things vascular medicine. We train our great fellows together, and a fantastic colleague, and a great resource for me and for you all. And I appreciate you being here, Dr. LeLeiko. And I'll let you pull up your slides.
Okay,
Thank you.
great. Thank you so much, Dr. Wells, for organizing all of this. And make sure I get the right talk up here. So it's really great to be here today and see some familiar faces, and get to talk about something that is all dear to all of us. So, okay. So, and I know in the interest of time, I'll try to move along so we have enough time for questions. But if there's anything you need me to clarify, please let me know. So initially, just a little definition. So what is SCAD? It's a acronym that we use all the time, but it stands for spontaneous coronary artery dissection. And this is basically defined by a separation in the layers of the blood vessel. So we're going to get into that with some nice schematics. But importantly, this is not associated with atherosclerosis, which is the typical kind of heart attack when you hear that people have had heart attacks. It's not associated with procedures, trauma, or anything else. This is spontaneous is important in that word. So 1 in 25 of all heart attacks, more or less, is actually due to SCAD. So this is really more common than we think. And in women, especially younger than 60, it's actually over 30%. So this is really not a small number. It's also the most common cause of heart attack in women who are pregnant or postpartum. Predominantly female, just like FMD, and with a mean age 44 to 53. So really, these are our younger women patients. And there is absolutely no racial or ethnic predisposition that's been found. So I'm hoping that this plays for us, because this is a, no, that's not going to work. Okay, that's all right.
Little play at the bottom. Oh, no, sorry.
No, okay, that's all right. It was just a nice little schematic. But basically, what's happening when you have SCAD? So there is some form of a hemorrhage that forms between the layers of the vessel. There's two hypotheses for that. One is the inside-out hypothesis, so the idea that there's a tear in the blood vessel, the blood rushes in, and then it extends down the vessel as the blood flow goes, and eventually can cause a thrombus and compress the blood flow to the vessel. The other hypothesis, and probably it's some combination of both in different patients, is what we call outside in, which is just spontaneous bleeding. There's very teeny blood vessels within the artery, within the layers of the artery that spontaneously hemorrhage, and then that can extend and cause compression. And particularly once this area thromboses, it can cause compression and block the blood flow distally past the lesion. So how does it feel? Patients present just like a heart attack. So when we see these patients in the emergency room, you may have symptoms similar to anyone else's heart attack. Of course, we know women may be a little bit different. So there's have to have a higher index of suspicion. But the majority of patients do have chest pain. A lot of them do have radiation or pain that extends down the arm, might be left arm, nausea, vomiting, sweating, shortness of breath. These are common symptoms of typical heart attack. And then you can see here on the right side of the screen some other possible symptoms. And this is not all inclusive. So certainly certain people might have different symptoms that they present with. Associated conditions, so obviously we just heard about fibromuscular dysplasia, and in our next talk we'll learn about the importance of screening for fibromuscular dysplasia in these patients. But we know that that does give us that is a risk factor for SCAD. Pregnancy and postpartum state, and that's defined as about 6 weeks after giving birth. Having more than 4 births is associated, and as well as genetic vascular diseases, as was touched on in the last talk, including Marfan's, Loeys-Dietz, vascular Ehlers-Danlos, and polycystic kidney disease. Hormones, and that shouldn't be a question mark, but there has, again, this is a big area of interest, but there has been some association specifically with oral contraceptives, birth control pills, and infertility drugs. And then finally, systemic inflammatory disorders. That's a big, broad category, but that includes things like rheumatologic disorders, rheumatoid arthritis, lupus, inflammatory bowel disease, so that is Crohn's disease, ulcerative colitis, and even celiac disease, and I'm sure I'm missing a few there. So these are just some things that have been associated. That doesn't mean that they are causative, but they're associated. So greater than 50% of our patients will be able to tell us about some trigger, and about half of them can actually describe an emotional trigger, some stress, emotional stress, and then about a third of those patients with intense physical stress. So that might be a really intense workout, it might be particularly heavy lifting, or what we call Valsalva, when people aren't breathing and they're pushing really hard. Certainly not all patients can report a trigger, but these are certain triggers that, of course, we're going to try to avoid in the future. And then this is just a slide giving you this kind of idea that we have these underlying diseases in the middle of the circle here, and then we have these environmental and outside influences that can lead to this, perfect storm of spontaneous coronary artery dissection. And then just to also make a note about pregnancy and postpartum associated SCAD, these patients tend to have the more severe presentation and course, so it's just sort of an important subset of our patients. The majority of these are not during pregnancy, they're actually after giving birth, but it can occur anytime. So genetics, you're going to see some similarities to what Dr. Wells just talked about. So there's no one gene. So it's not like Marfan's disease or some of these. There's not one gene that we can test for and say yes or no, you're going to have this, you're not going to have this. There's, a very, very small subset of patients that might, have familial SCAD, but all of our, we do not do testing for all of our patients. It's not indicated. That said, again, if patients have a family history, other people in the family with dissections, with aneurysms, with unexplained deaths or injuries, then we might be more likely to screen them for other connective tissues disorders. And then, of course, the factor, the EDN1, that's been associated with SCAD, and this is just an area of ongoing research, and that's associated with SCAD and fibromuscular dysplasia. So finally, how do we make the diagnosis? Really, the only real way to make a diagnosis is by coronary angiography, and that's the left heart catheterization, very similar to what Dr. Wells talked about when we look at the visceral arteries. Left heart catheterization, usually we can go through the wrist these days, sometimes through the leg. They loop a catheter up, access the coronary arteries, shoot dye, and see what's going on. This is traditionally what we do for traditional heart attacks in many instances, not all. So we're going to see a couple pictures as an example of this. Coronary CTA, which is a CT scan that looks at the coronaries, can be very good for looking at some things. It's not a great way to diagnose SCAD. It just doesn't have enough resolution, and it's easy to miss. So it's, some places that don't have the option for coronary angiography, this is something that can be done, but it's not a perfect option. And then, as we'll see, it can be difficult to diagnose, especially difficult to differentiate from our traditional atherosclerotic heart disease that might cause a heart attack. So we do have these tools, intravascular ultrasound, which we call IVUS, and optical coherence tomography, that I'll show you an example of. It's pretty amazing. It's an ultrasound or a little camera that's at the tip of the catheter that they can put into the vessel and see what's going on around it. So I'll show you an example of that. Okay, so I had put in a couple extra slides, but we have one slide, a couple slides that didn't make it in. So this is an example of coronary angiography. You can see the outline of the heart here, and then they're accessing the left coronary system and shooting dye. And you can see here, this little line here, that's the dissection, and this is what we call a type 1 SCAD. There's actually 3 different types, and this isn't the most common. So the most common SCAD actually looks very much like can look like atherosclerotic disease, and that's when it comes in handy to have these options. So this is, like I said, literally a catheter inside the blood vessel, and it can take a look around it, and here we can actually see the tear. This isn't common that it looks this pretty, but we can actually see the tear inside here, as opposed to atherosclerosis, which is going to look a lot more irregular. So this is an example of IVUS and then optical coherence tomography. I will say that clinically, sometimes the blood vessels are very small. Sometimes the lesion is far down in the vascular tree, and the blood vessels are like trees. As they get further out, they get smaller. So sometimes it's just not an option to do this, and we have to make a presumptive diagnosis. And one way that we do that, going back for a second, is you can see here, all the other blood vessels look nice and smooth. And it seems a little less likely that that patient might have atherosclerosis. So sometimes we have to use some deduction there. So I'm sorry that I missed my other slides, but another little push for the SCAD registry that I think we'll talk about a little more. First patient enrolled in 2019. These are the sites across the country, and we are included in that, and we enjoy enrolling patients so that we can further what we know about this disease. And here's our Emory SCAD program. So happy to take any questions. And then the next talk is going to be about management. So I think probably a lot of questions will be there for Dr. Mustafa.